You brush, you floss, you even mouthwash, and still, every morning your breath greets the world with a sour, sulfurous surprise. It's embarrassing, it's common, and most importantly, it's usually solvable if you know where to look first. In the next few minutes, I'll show you 3 very quick home checks that give you real clues about what's causing your morning bad breath. And I'll walk you through a safe, evidence-framed 48-hour diagnostic routine you can try tonight and tomorrow morning. If that routine doesn't help, you'll know exactly which clinician to see next and what to tell them. If this sounds useful, subscribe now and click the demo link. We'll show step-by-step techniques in the next video so you can do this safely. Start with the simplest truth. Morning breath is normal in degree, not destiny. Overnight, your mouth becomes a quieter, darker environment. Saliva slows down, air circulation changes, and a thin film of bacteria and debris builds up on the back of the tongue and in other hidden nooks. Those bacteria feed on proteins and release gases, most notably volatile sulfur compounds, or VSCs, which carry that characteristic rotten egg or onion-like smell. The chemistry is simple. The fix can be simple too, but only if you match the treatment to the source. To keep this practical, think in 3 common hiding places that create morning breath: the tongue's posterior surface where coating forms, periodontal pockets along the gum line where bacteria can hide and ferment debris, and tonsil crypts where trapped material can calcify into small stones. There are other causes: sinus drainage, dry mouth, reflux, medications, and even certain metabolic conditions, but those are less likely to produce a classic overnight sulfur smell and usually come with additional signs. Our goal here is diagnostic first. Identify the most likely reservoir, treat it with a short, safe trial, and then escalate deliberately if needed. Before you start anything invasive or expensive, try these 3 quick home checks in good light. They each take about a minute and together give you a surprisingly accurate map of what's going on. First, the tongue scrape smell test. Wash your hands, use a soft tongue scraper or the rounded edge of a toothbrush if that's all you have. Gently scrape from the back of the tongue forward 2 or 3 times, rinsing the scraper between strokes. Smell the residue on the scraper or on the toothbrush bristles. If the odor you detect is strong and sulfury, the back of your tongue is likely the main contributor. If the scrape smells only mildly of breath or is neutral, look to the next tests. If this test lights up with a strong sulfur smell, it suggests the bacterial coating on the tongue is a leading source, and tongue-directed cleaning is where you should start. Second, the gauze or dental floss smell test. Take a clean piece of gauze or a length of unwaxed floss.
Run it gently along the gum line, especially between teeth where food traps or where a restoration sits. Don't force it into tight spaces. Move it along gently. Smell the cloth or the floss after a few strokes. A pronounced offensive odor here points toward periodontal disease, active gum inflammation, or trapped debris around crowns, bridges, or partial dentures. If this flushed-out gauze test lights up, meaning the smell from the gum line is clearly offensive, this is a cue to stop aggressive home scraping and see your dentist, because pockets or inflamed gums often need professional cleaning and assessment. Third, the mirror console inspection. Stand in front of a bright mirror with a flashlight, open wide, and say, "Ah." Look for white, yellow, or calcified-looking flecks in the crevices of the tonsils. If you see small pale lumps or rounded material tucked into tonsil pockets, that could be tonsilliths, tonsil stones, which can cause persistent foul breath, especially first thing in the morning. If you don't see anything but you have ongoing throat clearing, bad taste, or a sensation of postnasal drip, consider that sinus drainage could be the culprit. If this mirror check lights up with visible material in the tonsils, document it with a photo if you can do so comfortably. This will be useful for an ENT visit. But do not try to dig around with picks or sharp objects. That can injure the tonsils and lead to bleeding or infection. After these 3 checks, you'll usually have a directional answer: tongue, gum, or tonsil postnasal source. Each of those routes calls for a different immediate strategy, but to keep things clean, safe, and diagnostic, I recommend a structured short trial you can realistically complete, what I call the 48-hour diagnostic trial. It's a focused, low-risk plan designed to reduce common, reversible causes of morning breath and tell you whether a home-based approach is likely to be enough. Here's the 48-hour diagnostic trial laid out so you can start tonight. Twice daily gentle tongue cleaning, twice daily interdental cleaning, after-meal water rinses and sugar-free xylitol gum is tolerated, 1 short alcohol-free mouthwash rinse twice a day, and warm saltwater gargles morning and night. Support that with deliberate hydration during the day and a saline nasal spray if you have signs of postnasal drip. Keep your overnight routine consistent. Avoid heavy late-night protein snacks, sleep with nasal breathing when possible, and swap a cotton pillowcase for a clean one if mouth breathing is suspected. To translate that into practical steps, tonight, after your usual brushing and flossing, add tongue cleaning, gently from the back toward the front, 2 to 3 strokes, then rinse. Perform an interdental clean with floss or interdental brushes, focusing especially where you noticed odor on the gauze floss test.
Do a brief 15-30 second rinse with an alcohol-free antiseptic or a mouthwash labeled alcohol-free, keeping to the product's recommended frequency, generally twice daily for short-term use. Finish with a warm salt water gargle. Dissolve about half a teaspoon of table salt in a cup of warm water, tilt your head back slightly, gargle gently for 10 to 15 seconds, and spit. If you have visible tonsil material, gargling can help loosen superficial debris without sharp manipulation. During the day, after meals, rinse your mouth with water. If you use a gum to stimulate saliva, choose xylitol-containing gum and chew for 5 to 10 minutes after eating. Xylitol helps reduce certain bacteria without being a long-term antiseptic. Also, make sure you're drinking water through the day. Dry mouths concentrate odor. Why this package? Each element targets a different mechanism. Tongue cleaning removes the dense coating that traps protein and anaerobic bacteria producing VSEs. Interdental cleaning removes trapped food and biofilm, feeding the same bacteria along the gum line. Saltwater gargles and alcohol-free rinses reduce superficial microbial load and soothe inflamed mucosa without the strong drying effects of alcohol. Hydration keeps saliva moving, and if you suspect postnasal drip, saline nasal spray addresses mucus pooling that can drip into the throat overnight. The whole plan is short-term, a diagnostic trial to see how much improvement you get in 48 hours. So what should you expect at the end of the 48 hours? If the back of tongue coating was the main problem, you'll often notice a clear improvement within a couple of days. The smell on the tongue scraper should be lighter, your morning breath less offensive, and your mouth feel cleaner on waking. If you're seeing dramatic progress, maintain a tailored tongue care routine. Gentle scraping each morning and maybe at night, and keep interdental cleaning regular. Represent this improvement in your notes. Note the smell intensity on day 0, again on day 1 morning and after the second night. This documentation matters when you consult a clinician later. If the 48-hour trial yields little change, especially if your gauze or floss test still gives a strong odor, or you notice bleeding when you use interdental tools, the likely issue is periodontal. Periodontal pockets can shelter bacteria that release VSEs and require professional cleaning, like scaling and root planing, to reduce pocket depth and biofilm. That process typically takes weeks to months to resolve and should be managed by a dentist or periodontist. The presence of bleeding, loose teeth, receding gums, or persistent gum tenderness during the trial are signals that a dental exam is indicated rather than more aggressive home measures. If your mirror tonsil check showed visible stones or persistent lump-like debris and the 48-hour measures don't change your morning breath, an ENT consult is reasonable. Some people have deep tonsil crypts that trap material and form recurrent stones. Clinicians can assess whether in-office removal, laser cryptolysis, or rarely tonsillectomy is appropriate. Again, do not try to dig these out yourself. Picking at tonsils can cause bleeding, infection, and pain. It's also important to note a few things we will not do as part of this first-line home approach. I will not recommend stopping prescribed medication. Instead, document them and bring that list to your clinician. I will not advise you to use strong antiseptics like chlorhexidine long-term without clinical supervision, because prolonged use carries risks to oral tissues and taste and can mask underlying problems without addressing root causes. And I will not encourage aggressive home removal of tonsil stones or invasive maneuvers on gums or restorations. As you run the 48-hour trial, keep a simple log. Document what you see and smell, the tongue scrape result, a note about whether your gauze or floss smelled strongly and whether you saw blood, a description of any tonsil material, your hydration and sleep patterns, did you breathe through your mouth, and any reflux symptoms, nighttime coughing, or unusual tastes. Even a brief 2-column note, morning and evening observations, helps your clinician diagnose more efficiently if you need to escalate care. Document this isn't a throwaway phrase, it's practical medicine. Clinicians, whether dentists, ENTs, or primary care providers, depend on a clear timeline and descriptions to guide testing and to avoid unnecessary treatments. A few safety pointers while you perform these tests and the trial. Use only soft, rounded tools for tongue cleaning. If you gag easily, work gradually and only scrape as far back as you tolerate. When flossing, be gentle. Forceful snapping can injure the papillae between teeth and cause bleeding that's not diagnostic. For rinses, stick to commercially available alcohol-free mouthwashes or a short-term saltwater regimen. If you have any nasal obstruction or sinus pain, choose a saline nasal spray rather than decongestant sprays for frequent use, unless otherwise directed by a clinician. And again, don't insert picks, cotton swabs, or sharp objects into tonsils or deep gum pockets. Let's pause on 2 common scenarios you're likely to meet in the first 48 hours and what they mean. Scenario A. The tongue scrape is strongly odorous, the gauze or floss is neutral, and the tonsils look clear. You follow the 48-hour plan and notice a clear drop in morning odor by day 2. Interpretation: posterior tongue coating is the principal source. Action: continue gentle tongue cleaning daily, keep interdental cleaning regular, and maintain hydration. Consider a professional dental cleaning if you haven't had one in 6 months, but this pattern often resolves with consistent home care and can be kept under control long-term with a simple maintenance routine.
Expect days to see meaningful improvement and maintain a weekly check of the tongue coating. Scenario B: the gauze or floss smells foul and you see bleeding with flossing. The tongue scrape is moderate and tonsils are clear. After 48 hours, there's no real improvement in smell and bleeding persists. Interpretation: periodontal disease is a likely driver. Action: schedule a dental appointment. The dentist or periodontist will examine pockets, measure depth, and recommend scaling and root planing or other therapies. Improvement here takes longer, often weeks to months, and requires professional intervention plus improved home care. If after 2 days you find no clear oral source, tongue and gums relatively neutral, but the problem persists, and you have ongoing throat clearing, nasal congestion, or an unpleasant tasting mucus, think ENT. Postnasal drip from chronic sinusitis or allergic rhinitis can deposit malodorous secretions in the throat overnight. Saline nasal irrigation and antihistamine adjustments can help some patients, but recurrent or unexplained symptoms merit ENT evaluation for nasal endoscopy or sinus imaging. There's also a small but important group whose breath is influenced by systemic factors. If your breath smells fruity or like acetone, or you have other systemic symptoms, such as increased thirst, frequent urination, unexplained fatigue, or rapid weight loss, see your primary care clinician promptly to check for metabolic causes like uncontrolled diabetes. If you notice an ammonia-type smell or persistent metallic taste, and you have known kidney disease or liver disease, coordinate with your primary care clinician and specialists. These systemic causes are less common as a pure morning breath problem, but they're essential not to miss if other symptoms point in that direction. As you prepare to start the 48-hour diagnostic trial, plan for simple documentation. A 2-day log can be as modest as 3 lines per entry. Morning smell rating, 1 to 5, tongue scrape odor, none mild strong, gauze or floss odor, none mild strong, any bleeding, presence of visible tonsil material, and a short note about sleep, mouth breathing versus nasal. If you can take photos of visible tonsil debris under good light, that helps in ENT later, but only if you can do it comfortably and without forcing a gag reflex. One more practical point about mouth rinses. Short-term use of alcohol-free antiseptic mouthwashes can reduce microbial load and be helpful during the 48-hour trial, but they are not a sustainable standalone solution. If the rinse seems to make a marked difference overnight, that's a helpful diagnostic clue that microbial load is central. Still, don't treat that as a substitute for proper mechanical cleaning and clinician assessment when indicated. If you rely on a mouthwash because your gums hurt when brushing, see a clinician instead of masking a symptom. All of this is designed to be low risk and high yield.
In clinical practice, I see many people who waste weeks trying random home remedies, heavy antiseptics, inappropriate picks in the throat, or stopping prescribed medications without medical oversight. Don't do that. Use the 48-hour trial, document findings, and then decide with clarity whether to continue conservative care or to escalate. If you're ready, here are a few concrete things to do right now before you begin the trial tonight. Gather a soft tongue scraper or a toothbrush with a tongue cleaning side, some floss or interdental brushes sized to your gaps, an alcohol-free mouthwash you know you tolerate, and a cup to mix warm salt water. Place a small notepad or a Notes app entry titled 48-Hour Breath Trial and set a morning alarm to record your first observations. That small bit of organization will make subsequent clinician visits much more productive if you need them. In the next segment, we'll walk through a slow-motion demonstration of the tongue scraping technique, proper interdental cleaning methods tailored to different restorations and appliances, and safe mirror tonsil inspection. We'll also overlay decision cues so you can match what you see during the trial to the right next step, dentist, ENT, or PCP, and I'll give you the exact 1-paragraph clinician scripts you can copy into a message or say at your appointment. For now, start the 48-hour diagnostic trial tonight, and note the first morning's findings carefully. They will be the most informative baseline you have. Now let's move into the practical, hands-on portion I promised, a careful, clinician-framed walkthrough of the techniques you'll use during the 48-hour diagnostic trial, what to look for as each step lights up, and exactly how to translate those observations into the next clinical move. The goal here is not to overload you with tools, but to give clear, repeatable actions you can do safely in your bathroom tonight and again tomorrow morning, with confidence that what you're doing is diagnostic as well as therapeutic. As you follow along, keep that little 48-hour breath trial note open so you can record results immediately after each step. Start with tongue cleaning. Use a soft, rounded tongue scraper or the back of a toothbrush if that's what's available. Stand in good light, tilt your head forward slightly, and breathe through your nose while you do this to reduce the gag reflex. Place the scraper as far back on the tongue as you can tolerate without gagging, then draw it forward in a single gentle motion toward the tip. Rinse the scraper under water between strokes. Aim for 2 to 3 passes, not long scrubbing, just consistent coverage of the posterior surface where coating accumulates. After the final scrape, smell the scraper. If you detect a strong sulfurous odor, that's the classic "if this test lights up" moment for posterior tongue coating. Repeat this same maneuver for the second morning of the trial and note whether the odor intensity drops.
If it does, that's a strong signal that tongue-directed cleaning is effective for you. Next, interdental cleaning. Choose floss or interdental brushes appropriate for your tooth spacing. If you have fixed restorations, crowns, bridges, partials, use a soft interdental brush sized to the space or a floss threader if necessary. Be gentle. Insert the floss with a sliding motion rather than snapping it between teeth. Rub gently against each side of the tooth down to the gum line and lift out. If you detect an offensive smell on the floss or gauze after a few strokes, and especially if you notice blood, this is the "if this test lights up" cue for possible periodontal pockets or inflamed gums. Don't try to probe deeper at home. Instead, document the finding and plan a dental appointment with the data you collected. Now the mirror tonsil inspection. Stand facing a bright light and use a flashlight if needed. Open wide, say "ah," and look for white or yellowish flecks topped into the surface of the tonsils. Small pale lumps are usually tonsil stones. If you find visible material, take a photo only if you can do so without forcing your gag reflex. Then log that you saw something and how large it appeared. If you see brisk bleeding or any area that looks raw or ulcerated, stop and seek professional evaluation rather than attempting any removal. If the tonsils show recurrent, clearly visible stones and the 48-hour measures don't help, that's a clear referral to ENT. A safe demonstration of the saltwater gargle. Dissolve roughly half a teaspoon of salt in a cup of warm water. Tilt your head back slightly, gargle for 10 to 15 seconds, and spit. Do this in the morning and before bed during the trial. For throat sensation from postnasal drip, combine this with an alcohol-free mouthwash rinse. The goal is not to desiccate the mouth, but to reduce superficial microbial burden and soothe mucosa. During the trial, it's crucial to monitor hydration and sleep patterns. If you suspect mouth breathing at night, try sleeping with a bedroom humidifier set to a comfortable level and consider positional changes. Sleeping on your side rather than on your back can sometimes reduce mouth opening and drooling. Replace pillowcases, and if you wear an oral appliance, follow the manufacturer's cleaning instructions nightly. If you use a CPAP, clean the mask and check humidification settings. Untreated CPAP mask leaks or poor cleaning can contribute to dryness and odor. What to expect from the 48-hour trial, in slightly more granular clinical language. If the posterior tonsil is the dominant reservoir, you will likely notice a measurable drop in the smell you perceive on the scraper and in your morning breath rating within 48 hours.
For periodontal-driven halitosis, the home trial will often not eradicate the odor because pocket biofilm is protected from surface measures. Instead, the gauze/floss smell and bleeding will persist and will be your cue to seek periodontally focused care. For tonsil-related odor, gargles and improved oral clearance may reduce symptoms if stones are superficial. Deeper, recurrent crypts usually require ENT assessment. If you hit a barrier during the trial, gagging that prevents adequate tongue cleaning, persistent bleeding with interdental cleaning, or an inability to visualize tonsils clearly, document that too and treat it as additional diagnostic data rather than as failure on your part. Document this. Write down what you could and could not do, the intensity of smell before and after each intervention, in any associated symptoms, such as bad taste, throat clearing, cough, nasal congestion, or heartburn. This record will speed diagnosis and avoid unnecessary repeat trials. Let's now step back and look at the next level clinical escalation. If the 48-hour diagnostic trial improves breath substantially, the conversation shifts to maintenance. Gentle tongue cleaning once or twice daily, interdental cleaning at least once daily, and staying hydrated are often enough to keep the problem at bay. Create a routine so this becomes as habitual as brushing. Consider a weekly tongue check. Scrape once, note coating, and decide whether to increase frequency temporarily. If improvement is partial, extend a structured approach for 2 weeks. The 2-week follow-up is an opportunity to add a short-term clinician touchpoint. Schedule or message your dentist with the documentation you've collected and ask for a focused assessment of periodontal health and restorations. If the 48-hour trial does not help and the gauze or floss test continues to be strongly odorous or bleeding, or if you notice mobile teeth or receding gums, prioritize a dental appointment. Your dentist will likely perform a periodontal exam that includes pocket probing in either full-mouth periapical series or a panoramic radiograph, depending on clinical suspicion. They may recommend scaling and root planing, and depending on response, adjunctive measures like localized antimicrobials or referral to a periodontist. Expect the timeline for improvement to be measured in weeks to months, not days. Document this expectation for yourself. Periodontal care is effective, but it takes time and consistent home care to stabilize tissues. If your mouth-based tests are neutral but you continue to have morning breath alongside nasal symptoms, itchy eyes, nighttime congestion, waking with a postnasal taste, or if you experience persistent throat clearing, cough, or mucus in the back of the throat, an ENT evaluation is appropriate. The ENT will perform a nasal and throat exam and may do nasal endoscopy to visualize the sinus drainage pathways in the posterior nasopharynx.
Sinonasal inflammation, chronic rhinosinusitis, or allergic rhinitis can contribute to overnight accumulation of malodorous secretions that drip down to the throat. Imaging, such as a sinus CT, is reserved for cases with persistent symptoms or when endoscopy suggests obstructive disease or anatomical contributors. When to bring primary care into the picture? Systemic causes of breath odor are rare but important. If you notice a fruity or acetone-like smell, unintentional weight loss, excessive thirst, frequent urination, or fatigue, arrange prompt primary care follow-up for evaluation of glucose control. If the breath smells of ammonia, or if you have chronic fatigue, nausea, or known kidney disease, coordinate with your primary care clinician for renal function testing. If there's a persistent metallic taste or signs of chronic liver disease, jaundice, right upper quadrant pain, significant fatigue, bring it to your clinician's attention. Don't use these as excuses for alarm. Most morning breath is local and manageably treated, but being alert to systemic red flags is sensible. To help you speak directly and efficiently with clinicians if escalation is needed, here are short copy-ready clinician scripts you can use as written messages or as the opening line of your appointment. These are intentionally concise and fact-focused, so they communicate the diagnostic trail you already ran. For the dentist, hi, I've had persistent strong morning breath for X weeks. I completed a 48-hour diagnostic trial, gentle tongue scraping twice daily, interdental cleaning twice daily, saline gargles and alcohol-free rinse, and documented observations. Morning breath rating on day 0 equals X out of 5, day 1 equals X out of 5, day 2 equals X out of 5. Gauze/floss smell during trial was none, mild, strong. Bleeding with interdental cleaning was yes, no, and I noticed restorations, loose teeth, receding gums. Can you evaluate for periodontal pockets and restorations and advise next steps? For the ENT, I have persistent morning bad breath despite 2 days of targeted oral care. Tongue and gum tests were neutral, moderate odor, but I have ongoing throat clearing and nasal congestion, and noticed mucus in the back of my throat on waking. I completed saline nasal spray and gargling during the 48-hour trial with minimal change. Could you evaluate for postnasal drip or chronic sinusitis and advise whether nasal endoscopy is appropriate? For the primary care clinician, I've had persistent morning breath for duration that does not improve with a 48-hour oral care trial. I have additional symptoms of polydipsia, polyuria, fatigue, weight loss, metallic taste, nausea. My medication list includes list. Could we review whether systemic causes like diabetes, renal or hepatic issues, or medication side effects might be contributing and what initial labs you recommend?
Each script is short, factual, and oriented to the trials and observations you've already completed. This makes follow-up more efficient and clinically useful. Document this. Clinicians appreciate a clear timeline and a concrete description of what the patient has already tried. Let's make the 2-week structured follow-up concrete. If the 48-hour trial gave partial improvement, continue the daily routine for up to 2 weeks, adding a few intentional measures. First, set a daily morning and evening log entry that includes a smell rating, 0 to 5, any bleeding with interdental cleaning, and whether the tongue scraper smell changed from the previous day. If you're using xylitol after meals, record how often you chew and whether it changes dry mouth sensation. If you suspect reflux, note any heartburn, nocturnal coughing, or acid taste. After 2 weeks, review your log. If you document a steady downward trend in odor and symptoms, maintain the regimen and schedule a preventive dental visit if you haven't had one within 6 months. If there's no meaningful change, or if you notice worsening signs, use the clinician scripts above and request targeted evaluation. Now some realistic expectations about timelines and probabilities. Posterior tongue coating often responds quickly. Many people notice meaningful improvement within days if the tongue is the main source. Periodontal disease will usually need professional intervention and may show slow improvement over weeks to months following scaling and root planing. Tonsil crypt-related odor can be variable. Superficial stones may respond to gargling and improved oral clearance, while deep, recurrent tonsiloliths sometimes require ENT procedures.
Resolution here may take weeks to months, depending on the chosen intervention. ENT-driven causes, such as chronic sinusitis, can require a trial of medical therapy and possibly procedural interventions. Expect variable timelines. Systemic causes require targeted management of the underlying disease and are not generally quick fixes for breath odor. Safety first. Do not attempt forceful removal of tonsil stones at home with sharp implements. Do not use unprescribed topical antibiotics or home concoctions that can burn or desiccate tissues. If you experience bleeding from the throat that is brisk or difficult to stop, significant pain, fever, difficulty breathing, or trouble swallowing, seek urgent evaluation. These are red flags. Specifically, get urgent care or emergency attention for fever with throat swelling, progressive difficulty breathing or swallowing, visible blood in saliva or sputum, or sudden unexplained weight loss accompanied by persistent smell changes. These are not typical of routine morning breath and need prompt assessment. Now meet 3 composite patients whose pathways reflect common outcomes you might recognize. Anna is in her 30s and woke up complaining of a strong sulfur smell despite nightly brushing.
Her tongue scrape test produced a pronounced odor. The gauze or floss smelled neutral, and tonsils were clear on mirror exam. She completed the 48-hour diagnostic trial faithfully and logged a sharp drop in morning smell rating from 4 to 1 within 2 days. She kept tongue scraping in her daily routine and scheduled a routine dental cleaning. Over the next month, her morning breath remained manageable with a maintenance scraper session each morning and weekly tongue checks. Anna's path illustrates a common, quick response pattern when the posterior tongue is the dominant source. Marcus is a middle-aged man who noticed bad morning breath for months and felt increasingly embarrassed in social situations. His tongue scrape was only mildly odorous, but his gauze or floss test produced a persistent strong smell and bleeding when he flossed. During the 48-hour trial, there was little improvement, and bleeding persisted. He used the clinician script to request a dental appointment. The dentist performed periodontal probing and noted pocketing consistent with moderate periodontitis. Scaling and root planing were recommended. Marcus completed the recommended therapy and followed up at 3 months with improved pocket depths and a significant reduction in morning breath, but the improvement followed weeks of therapy and careful home care. Marcus's pathway reflects how periodontal disease often requires professional treatment and longer timelines. Leah is in her 50s and presented with morning breath that did not improve after 2 days of oral care. Her tongue and gum tests were unremarkable, but she had persistent throat clearing, nasal congestion, and a history of seasonal allergies. She used saline nasal spray during the 48-hour trial with little change. An ENT evaluated her with nasal endoscopy and identified chronic rhinosinusitis with posterior drainage. After a course of topical nasal steroids, improved saline irrigations, and targeted allergy management, her morning breath reduced substantially over several weeks. Leah's case shows when ENT assessment and targeted sinus treatment are the right escalation. Throughout all of this, diet and medications can influence breath. Heavy late-night protein meals and certain foods like garlic and onions can magnify morning breath. Avoid large protein-rich meals right before bed if you're troubleshooting. Alcohol and tobacco dry the mouth and increase morning odor. Reducing or eliminating them improves breath and overall oral health. Certain medications cause dry mouth by reducing saliva flow. If you suspect this, document which medications you take and bring that list to your clinician. Do not stop any medication without your prescriber's guidance. Some supplements and foods like fish oil or garlic supplements can give breath an identifiable smell. If you take these regularly, note them in your log as potential contributors.
A short note on mouthwashes and antiseptics. Short-term use of an alcohol-free antiseptic mouthwash can be part of the 48-hour trial, but long-term use of strong antiseptics like chlorhexidine should be reserved for clinician guidance because chronic use can alter taste and oral microbiome balance and mask underlying problems. If a mouthwash seems to dramatically reduce odor short-term, that's diagnostically helpful, documented, but don't lean on a rinse as a permanent solution without professional advice. Practical maintenance tips to reduce recurrence. Replace your toothbrush every 3 months or sooner after illness. Clean removable dental appliances nightly according to manufacturer instructions. If you wear partial dentures, remove and rinse them at night. If you grind or clench, discuss appliance hygiene with your dentist. For chronic dry mouth, try scheduled sips of water, sugar-free lozenges, or xylitol gum during the day to stimulate saliva, and consider over-the-counter saliva substitutes if dryness is persistent. Again, bring symptoms to your clinician for a medication review and targeted options. For those using CPAP, check mask fit and humidification. Poor mask fit can cause leaks that dry the mouth, and inadequate humidification can increase dryness and morning odor. Clean CPAP equipment regularly per manufacturer guidelines to avoid microbial buildup that might contribute to smell. Documentation templates that are practical and short work best. For a 2-week log, create entries that include date and time, morning breath rating 0 to 5, tongue scrape odor none mild or strong, gauze floss odor none mild or strong, bleeding yes or no, Visible tonsil material, yes or no? Sleep notes, mouth breathing, yes or no? Position, alcohol use. Diet notes, late night protein, yes or no? And any reflux or systemic symptoms. At the end of the 2 weeks, add a 1-paragraph summary for your clinician. After 2-week home trial, odor improved, unchanged, or worse. Main findings were list, seeking dental ENT PCP evaluation. Bring this summary to appointments or paste it into a message. If you do see a clinician, here are some of the tests and procedures they may consider and why. Dentists will examine restorations for overhangs or poorly fitting margins that trap food, perform periodontal probing, and consider radiographs. Periodontists may recommend scaling and root planing, localized antimicrobial therapy, or surgical pocket reduction for persistent deep pockets. ENT specialists may perform nasal endoscopy to visualize the posterior nasal cavity and tonsils. Treatment may include topical therapies, in-office removal of superficial tonsil stones, or in rare refractory cases, procedures to reduce crypt depth. Primary care clinicians will review medications, order blood glucose testing, metabolic panels including kidney and liver function tests if systemic disease is suspected, and coordinate with specialists as needed.
These are clinician-delivered options. They confirm the importance of the stepwise approach you've already been using. Red flags that require urgent attention are specific and should trigger immediate medical review. Fever accompanied by throat swelling or a rapidly enlarging neck mass, progressive difficulty breathing or swallowing, visible blood in saliva or sputum, sudden unexplained weight loss with persistent smell change, or neurologic symptoms with breath changes such as slurred speech or facial weakness. If you experience any of these, seek urgent care or emergency attention rather than waiting for a scheduled clinic appointment. A few frequently asked questions people often have while running the 48-hour trial are worth addressing here. First, can I use a tongue brush instead of a scraper? Yes, soft tongue brushes are effective when used gently and can be better tolerated for people with strong gag reflexes. The key is reaching the posterior tongue surface as comfortably as possible and removing biofilm without trauma. Second, is there a right frequency for tongue cleaning? Start with once each morning, and if the tongue remains coated, add an evening session until the coating is reduced. Long-term, most people find once daily sufficient. Third, what if I have dental work like implants or bridges? Are interdental brushes safe? Yes, choose the correct size brush and be gentle. Floss threaders or water flossers can be alternatives, but if bleeding persists, see your dentist. Another practical tip: when you take a photo of visible tonsil material or oral findings for your clinician, use good light, avoid forcing your mouth open beyond comfort, and take multiple short attempts rather than one forced effort. If you can't get a useful photo, a detailed written description, size, color, and associated symptoms can be almost as helpful. Behavioral measures that reduce recurrence include avoiding heavy late-night meals, limiting alcohol and tobacco, addressing sleep-disordered breathing if present, optimizing nasal allergy control, and maintaining regular dental visits. If you have dental appliances or orthodontic hardware, follow clinician-recommended cleaning regimens and bring up halitosis as a routine concern in your dental visits rather than waiting until it's severe. Finally, let's close with a compact, usable checklist you can save or screenshot as a bedside reminder of the 48-hour diagnostic trial and the 2-week follow-up. Keep a small, printed or digital card that says, tonight, after brushing and flossing, do tongue scraping, 2 to 3 gentle strokes, interdental cleaning, 15 to 30-second alcohol-free rinse, warm saltwater gargle. Daytime, after meals, rinse with water and chew xylitol gum if tolerated. Nightly, record morning smell rating and tongue scraper smell. 2-day milestone, evaluate change. 2-week milestone, summarize findings and decide on dental, ENT, PCP referral using the clinician scripts. Remember, document this.
If you've completed the trial and you're heading to an appointment, use the clinician scripts verbatim or paste them into a message to speed triage. Bring your 2-week log, any photos you took, and your medication list. Be honest about habits that might contribute: tobacco, alcohol, supplements, sleep patterns, because clinicians need that context to make good recommendations. I know morning bad breath can feel embarrassing and socially isolating, but you're not alone, and importantly, most causes are identifiable and treatable when approached in an organized way. Start with the 48-hour diagnostic trial tonight. Document what you see and smell, and use the 2-week follow-up plan if needed. If the tests light up in different areas, escalate appropriately. Dental, periodontal for gum line odor and bleeding, ENT for visible or recurrent tonsil material and persistent postnasal drip, and primary care for systemic clues. Keep safety front and center. No sharp tools in the throat, no stopping prescribed medicines without clinician guidance, and no long-term reliance on strong antiseptics without medical supervision. If you want to master the techniques, safe tongue scraping, proper interdental cleaning for different restoration types, and a careful mirror tonsil inspection,
Watch the hands-on demonstration now for slow-motion technique and clinician overlays that show what to do and what to avoid. Save the downloadable 48-hour checklist and the 2-week log template in the description so you can start tonight. If, after using the checklist and scripts, your morning breath persists, bring your documentation to a clinician and use the scripts we provided to get focused, efficient care. You don't have to figure this out alone. With a few targeted steps, you'll often move from frustration to control, and in most cases, that control can be sustained with simple maintenance.